Center for Orthopedics, Imperial Health Center for Orthopedics. This talk tonight is hosted by myself as well as our group that Imperial Health Center for Orthopedics, but also in conjunction with Christic St. Patrick's Hospital, has helped us to invest in the technology that allows us to bring some of the best, most cutting-edge technology to this area. We're the only center from here to, I guess there's a robot in Lafayette, and then really to Houston that has this type of technology. And it's really revolutionized the way that we're able to do hip and knee replacements in particular. And in the future, we think it'll help us to do other types of surgeries as well. So tonight we're talking about robotic-assisted partial hip and total knee partial knee and total hip replacements. We'll go through some different anatomy. We'll talk about the causes of arthritis, some of the different conservative treatment options for arthritis, and then really what I want to focus on is kind of how we do the surgery, emphasizing how this technology has helped revolutionize this process. And at the end, we'll open it up for discussion and questions, because I find that's usually the most beneficial for people. This is kind of the same overview we just talked about. Obviously, our joints are involved in everything we do, from walking to getting around, bending, turning, twisting, lifting, going to the grocery store, driving a car. And when these joints get diseased or arthritic, they become painful. And of course, it can limit your mobility, limit your activities, limit your ability to be happy or enjoy the things that you used to enjoy in life. The word arthritis, what does the word arthritis mean? So this is a confusing concept for everyone. The word arthritis simply means the process whereby the cartilage in our joints is lost. So all of our bones come together to form joints, and at the joint level, they're lined by cartilage. The cartilage is what makes them glide smoothly and freely together. And over time, that cartilage is worn out or goes away. That's what the word arthritis means. Arthritis simply means loss of cartilage. So I think it's important because almost everyone that we operate on afterwards will ask questions to the effect of, were you able to get rid of all the arthritis? Again, arthritis means loss of cartilage, and so any joint replacement that we do is replacing those surfaces that have already been damaged or have already had the cartilage lost. So we're not going in there looking for a thing to take out necessarily. It's just the process whereby that cartilage is lost. Arthritic pain can be constant for some people, and for other people it comes and goes. For some people it's worse after they sit for a long time. For other people it's worse after they've been up on their joints for a long time. It can occur with movement as well. It can be located in one spot. Obviously it can be in both knees or both hips. It doesn't have to necessarily be isolated to one particular joint. Lots and lots of Americans have arthritis. It's the leading cause of, one of the most highest leading causes of disability in Americans. Up to 21 million Americans suffer from osteoarthritis, and it's resulting in a disability, and it's resulting in them not having the activities that they'd like to do in their life. The weight that you have on your belly does play a role. For knees, it's a 4-to-1 ratio. The point being that, of course, weight loss can make some difference, but that's not something that we necessarily harp on. I think it's important to understand the ratio. A pound off the belly takes 4 pounds off the knee, and that math can add up really quickly. 10 pounds would be a 40-pound pressure differential. But again, once you've developed severe bone-to-bone arthritis, that's not going to make the arthritis go away. Exercise can be beneficial at times. Everyone may have seen the commercial a long time ago. Celebrex used to have a commercial that said, a body that remains in motion tends to stay in motion. I think the point being that continuing to move your joints and use your joints through time and through life can really help to maintain those joints and actually alleviate pain. So low impact exercise not only can be beneficial for your heart and weight loss, but also can help your joints to actually feel better. So let's begin talking specifically about the hip. This is the hip joint. The hip joint is a ball and socket joint. Physically, your hip joint is located here, kind of in your groin area, in that fold, in the crease of your leg. A common misperception of patients is that over here is their hip, and that's certainly the side of the hip over here, but that's not the hip joint. The hip joint, again, is deep within the pelvis in the center here. As you can see here, it's a ball, and the socket's deep to that. This light blue stuff is what they're representing as the cartilage layer that's lining the end of that bone. We'll come back to this in a second. But continue with this, talk about the cartilage. This is the normal cartilage, the pelvic bones up above, the femur or thigh bones down below. And over time, as that cartilage wears away, you can see where the cartilage is worn away. That's what results in arthritis, and that's what results in the pain. So the question that people say is, I have this pain in my buttocks or I have this pain in my low back, and of course, a lot of people want to call this their hip, but that's not typically the hip joint itself. It's important to know that in regards to hip arthritis or in hips in general, hip pain can mimic back pain and back pain can mimic hip pain. And furthermore, for the vast majority of patients, they have some overlap of the two. So most people that have a fair amount of hip arthritis also have some back arthritis or vice versa. And so it's important for us early on to figure out what is the true source of your pain. So in other words, we don't want to just go in and do a hip replacement on everyone that has a little bit of hip arthritis if the majority of their symptoms are, of course, coming from their back. So this is an x-ray of a person with a normal hip, and this is how we are able to look at someone's radiographically and say, well, you do or don't have arthritis. Of course, we can't see the cartilage here, but what we can see is that you have a normal ball, a normal socket, and there's this reasonable gap between the two. If you look at the other x-ray on this side, you can see that there's no longer a gap between those. And this person, of course, has severe arthritis. All the cartilage is worn away. That gap is completely gone. And so ultimately, their real treatment is headed towards a hip replacement surgery. Again, lots and lots of people have osteoarthritis. 27 million people are suffering from osteoarthritis. There's different sources of arthritis that can result in hip pain. Osteoarthritis is the most common type, and that's just a wear and tear. That's just over the course of your lifetime, the cartilage layer that you had there was only a few millimeters thin, has worn away. But it's not necessarily due to any sort of a disease. It's just because you've lived long enough to develop some arthritis. Rheumatoid arthritis, on the other hand, is a specific type of arthritis whereby your body actually attacks the joint lining and then ultimately results in that joint wearing out. This is the kind of arthritis that you have to go see a rheumatologist for. There's special medicines that you take. Again, a lot different than what most people have as the source of their hip arthritis. And then finally, in regards to the hip, there's another type of arthritis that can result from what's called avascular necrosis, or AVN, and that is the ball can lose its blood supply over time. There's a multitude of reasons that can occur, but when that happens, people typically develop fairly advanced arthritis at a fairly quick rate. So treatment options for hip pain. If it's truly coming from your hip, of course, we talked about physical therapy and exercise. We talked about dieting and weight loss. Certainly anyone who has hip arthritis can place themselves on a walker or place themselves on a cane. It will offload or take some pressure off that joint. You could try heat or cold. And then you can take some anti-inflammatory type medicines. Aleve and Advil are over-the-counter anti-inflammatories, but there's obviously a whole host of prescription ones as well. The bottom line, or the takeaway for me in regards to hip arthritis is, unfortunately, unlike knees, which we'll come to in a second, there's not a lot of options. You either can, essentially, the things I can offer you are, you can try some medicines and, like I said, some exercises, but ultimately, if you have advanced hip arthritis, really you're pretty much headed towards a hip replacement once you've decided you don't want to live with that kind of pain any longer. So what is a hip replacement? A hip replacement is that we go in there and we clean out the old socket that doesn't have any cartilage. We put a new metal socket, which then has a plastic liner, and we've removed the old ball that also had all the cartilage loss, and now there's a stem that's going to go down inside this marrow cavity of the bone to support a new ball. This will all make more sense in a second. This is, again, same thing, talking about how the parts work. Are the parts heavy? They're not really heavy. They weigh less than a pound, and if you do go through a metal detector, especially at an airport, nowadays they do tend to set off the metal detector. And we can, again, address all these questions at the end. So, we do lots of hip replacements. In the nation, we do 300,000. They anticipate that by 2030, this is going to more than double as the baby boomer age group is continuing to age, as people are becoming or demanding to be more active. More and more people are requesting that we do joint replacement surgeries. This is the Mako robot. This is the piece of one of the three pieces of equipment that's involved in the surgery. You can see it has wheels. It gets wheeled into the room and it gets wheeled up next to you at a particular point during the surgery. We'll show you these video in a moment. But I think it's important to realize that this robot is controlled by the surgeon. So this robot, unlike some other robots in different types of surgery settings, does not do the surgery. It's there to help guide the surgeon and make sure that the surgeon does things properly. But it's not doing any portion of the procedure. The way the robot works is once the decision is made that you would benefit from a hip replacement surgery, you have a CT scan. A CT scan is like a fancier x-ray, but it's three-dimensional. It's for your body, of course. That CT scan is loaded into the Mako robot. And then at the time, before surgery and during surgery, we develop a plan that's personalized to you, that we say, we want to put your hip socket in exactly this position and this turn and rotate it this way. And then once we get into surgery, it allows us to position our components in exactly the position that we have planned, no matter what happens to your body during surgery. And that's the huge advantage of this. We'll go through this in a second as we show this video. Let me bring up this video, and we'll start talking about this, and then I'll highlight some of the points that make this thing pretty amazing. So these are the components. There's this little eye that kind of looks at things, and it can look at the robot and some different trackers that we have. You saw another screen over there. It was a screen that I can look at visually during the surgery. There's another guy in the background that's running the other screen. And then this is the robot. Again, we load the CT scan. It goes into the Mako robot so that it knows what your pelvis and hip and everything looks like beforehand. It shows me this thing beforehand. This is a model of the bone, of course. You can see where they're moving different things on the video up here, trying to emulate what we want to do surgically. I use a probe during surgery on different portions of the bone that tells, after that, the robot says, now I know where you are. It's called registering your bone, so it knows where you are. From there, we're able to put the stem down inside that marrow cavity of the bone, which is going to support the new ball. Same thing on the socket side. Again, register that socket. You can see that green acetabulum, or the socket side moving around. It's telling us where to put the socket. We bring in the reamer, which helps clean out the socket for placement of the new socket. It puts it in exactly the perfect position within 1 millimeter and within 1 degree of freedom. Once we've cleaned that out, it then also makes sure that once we put the final implant in, it's in the same exact position that we just cleaned out. And as you can imagine, before we had this technology, we used, well, I'll let you see this. So the plastic liner snaps into the socket, and now you have metal rubbing on plastic. All the arthritis has gone from the hip. And again, exactly as we planned before the surgery, we end up with exactly what we wanted after the surgery. You can imagine, first of all, 15 years ago, we used to do hip replacements through a very large incision. And then patients demanded, or over time, it caught on that we could do them through smaller and smaller incisions. But obviously, the smaller our incision gets, the less we can see. I mean, we can see what we need to see, but we can't see the remainder of the anatomy. And as such, you can imagine that as our field of vision gets more and more narrowed, all we're able to look at is, as we're looking into your hip joint, we're trying to figure out where is your socket. We can see the socket, but we can't tell if your body gets pulled. You know, if someone pulling on this front retractor pulls you a few degrees this way or a few degrees this way, or maybe you have broad shoulders and makes you tilt one way or the other way. The point being, there was a lot of mechanical things that we had to do to try to judge exactly where these components went, but of course, it was not near as precise as what we can do today, within 1 degree of freedom and 1 millimeter of where we want to be. So it's pretty impressive technology. It doesn't perform the surgery. We talked about that. It doesn't make its own decisions. It doesn't move in any way without me guiding it. The advantages of the robot, besides the precise position of the components, which will certainly result in longer lifespan of the components, it also, I believe, makes us use a slightly smaller incision because, again, now we don't need quite as much visualization because we can do everything robotically. It is faster in terms of how we can do the surgery, which therefore cuts down on your infection risk because you're open for your skin and incision's open for a shorter amount of time. It allows for less blood loss because we can do some of these steps in a little bit more rapid manner. Allows us to restore the leg length more perfectly. Of course, everyone wants their legs to be even at the end of a hip replacement. And it decreases dramatically the risk that ball will pop out of the socket over time. Tremendous number of benefits. After a hip replacement, you can have very realistic expectations that you can return to a lot of different activities, including walking, swimming, golfing, driving, hiking, biking, dancing. Even up to doubles tennis is allowed and recommended by the American Academy of Orthopedic Surgeons. So you can be very active. I don't think that people would recommend that you take up marathon running necessarily, but beyond that, you can do virtually anything you want on a day-to-day basis. So moving on to the knee, again, we begin with the anatomy lesson. The femur is the thigh bone up top. The shin bone is called the tibia. The bones are, of course, lined with this cartilage. In the knee, there's another special shock absorber cushion called the meniscus. The meniscus can wear out over time, just like the articular cartilage can wear out over time. This is what an arthritic knee looks like. That cartilage is worn away. On x-ray, again, there's a gap that's maintained between the two bones, and once you've developed an arthritic knee, that gap is now lost. And so you can see in this particular patient, he has bone-on-bone arthritis, bone-on-bone knee arthritis on the inside half of his knee. Again, we've said this before, but lots of Americans have osteoarthritis. It's very common. In the knee, this can also occur in the hip, but in the knee it's more common because of the exposure the knee sees. You can develop post-traumatic arthritis. That is, I got in a car wreck, or I jumped off a ladder and I tore my ACL, my meniscus, and now I have arthritis. That's post-traumatic arthritis. So obviously you got arthritis at a much younger age than you would have if you just had wear and tear arthritis. Treatment options for the knee we talked about, they're a little bit different than the hip. Some of them, of course, overlap. You can do therapy and exercises to build up especially your quadricep or thigh muscle. Weight loss, we said earlier, is a 4-to-1 ratio. Canes, walkers, etc. Medications, we do have some different options. Of course, we have the anti-inflammatories. We can do cortisone shots. That's an easy joint to inject. The knee is, of course, up here in the front. We can feel it, and we can easily inject your knee with cortisone. There's some other medicines that people talk about. People call them rooster comb shots or lubricant type shots, typically given in a series of injections, tend to be slightly better than cortisone at times. Certainly something that people try. There's some other newer evolving injection technologies that are coming on the forefront which may be beneficial in the future. And then ultimately, again, if you have failed all the conservative things, move on to some sort of replacement surgery if you're not a candidate for an arthroscopic surgery. The replacement surgery options are either partial knee replacement or total knee replacement. We'll kind of go through for a second. Partial knee replacement implies just what the name says. We replace part of the knee. So a total knee replacement would mean that this piece of metal would extend across here, and that this piece of plastic would extend across here, and then again, the whole thigh bone side as well as the kneecap area would be resurfaced. In the partial knee replacement, we only choose to replace the part that's diseased. And so for a lot of people, this is very appealing. They say to themselves, if 2/3 of my knee is normal, why would I want to replace those two-thirds of my knee that are normal? Why don't I just replace the 1/3 of the knee that's wore out? And so we can replace the inside half of the knee, we can replace the outside half of the knee, we can replace the kneecap area of the knee, or you can even consider potentially doing 2 partial knee replacements, although I'm not sure there's a tremendous amount of utility for that. So we talked about hip replacements, 300,000 a year. We're doing 600,000 knee replacements a year annually, and again, same idea that this is expected to double over the next decade or so. Questions, same sort of thing. Are they heavy? Can we set off a metal detector? Can you be allergic? All that stuff is, the answers are the same. It's not very heavy. It will set off a metal detector, and it's exceedingly rare that you could have an allergic reaction to the implant. Same idea in terms of how we prepare for the Mako robot. We get a CT scan beforehand. We plan it out, personalized for your knee. We go through extensive planning to make sure that every x-ray we do looks identical to this, which is that thing just barely fits on the end of the bone, barely covers the top of the shin bone. The knee alignment is perfectly straight as we want. But again, let's go through this video briefly. We'll go ahead and start this video. So a little different device. You can see here it's a little burr. It's a 6mm burr currently. They're coming out with a slightly bigger burr soon, which will help us do this surgery even faster, which will be better for you guys. But the same idea, same equipment. Someone runs this one. I look at the other screen. That's the robot. It has the arm, has the burr on the end that we can move in different directions. And literally, we burr away 1 or 2 or 3 millimeters of bone. It's pretty impressive the amount of bone sparing that we use, and furthermore, how precise we can be. So before surgery, before we've done anything, CT's been loaded. We move your knee through a range of motion. You can see up here this graph. This shows how tight the knee is in different places. At the bottom, the gentleman's moving the components in different places, and it's changing this graph so that we can say, well, now we've got our knee almost perfectly balanced. You can see where it's all within 1 millimeter across there. And so then we say, well, that's where we want our components to go. And we look at them in different arrays, different views, and try to figure it out where we want to put everything. And that's all before we've even done anything surgically. And then from that point forward, literally, it's like a paintbrush. and we use that burr and look on the screen. It's like playing a video game and burr away the part of the bone that we need to take away. Same thing on the thigh bone side. Again, you can see, I presume you can see it, but that very, very minimal amount of bone that's being trimmed away on the end of the thigh bone, just barely enough so these components can be cemented into place and held into place. That's the shin bone side with the plastic liner on top, and then the thigh bone side gets cemented together. And then, again, at the end of the surgery, you now have metal rubbing on plastic. All the arthritis is gone from the knee. You can get back to doing all the things that you want to do. Partial knee replacement is like hip replacement. It's one of the most gratifying surgeries we do. And again, this is a bit different than total knee replacement. We can touch on that later, but tonight's talk is, of course, talking about partial knee replacement. Do all the same activities we talked about: hiking, biking, golfing, doubles tennis, going to the grocery store, of course, sitting in a movie theater, driving a car. We're doing lots of these. This number continues to increase. This data is old. This is from 2015. We had done 16,000 in the country they're talking about. And in 2016, I know that number is already far surpassed that. Basically, is your hip or knee pain slowing you down? Is it keeping you from doing things you want to do? And is it affecting your ability to get around or care for yourself? Then you need to consider doing something to make your pain better.